Hello, everyone. Again, she already said my name, and I've put out there that I've got a lot of credentials, and basically all that is a test-taking junkie. That's what I am. I like to take tests to let people know I know what I'm talking about. It works because it looks really good up there, doesn't it? It's like an alphabet. But don't worry about that. Anyway, I am on at the 1:45 to keep you awake, so if you haven't heard me speak before, hello. Enjoy. I am here for your enjoyment. The best thing we can do is kind of make this as interesting as we can. I know a lot of people don't really like to hear about billing codes and all the rules. I have a very short period of time, right? We wanted to get as many type of subject matter experts in here so they could hear everybody. So if, for instance, I don't cover something that you need to hear about or you came today, please don't forget, if you hadn't heard already, I will be speaking all day, and you can enjoy that, Monday, and I don't even know where it is. That's awful. But look up the Ohio Children's Alliance. Is anybody going to that? I see a few hands. Come see me when you go to that. Myself and Chris Smalley will be speaking all day about codes and getting more in depth. Today we're just going to hit the surface to get as much information to you as we can based on some of the feedback that I've gotten as I've gone out and talked on what is causing you the most difficulty with coding. So let's go ahead. We should, we have to have a thing. Do you want me to do a move it along or?
Yeah, just twitch.
We have to have something fun.
There you go.
She wants me to twitch. You don't want me to have like a twitch and go.
How about twerk?
No, we're not twerking up here. That's not what coding's all about. And although I need to keep people awake, I think we have to draw a line somewhere. Okay. So what are we talking about in this session? Review of what the NCCI edits are, what that means, and hopefully I'll give you some insight today that'll give you a better idea if you haven't taking that NCI manual and read the whole thing cover to cover. E&M documentation, this is for your prescribers, so I'm just going to hit that very lightly. Believe me, this can be an all-day discussion. And if you've heard me speak before, I get a lot of work as an expert witness, and I can tell you that if you want to know how difficult it is in E&M coding, I can tell you that I've actually sat in front of a jury in court for an entire 8 hours defending documentation on E&M. So it can be pretty wild. I'm going to quickly give you an idea of what's on the horizon for E&M, not to scare you or even divert from where we are now, because really what's important is where we are now. But how many of you have heard there's a new final rule and that evaluation management codes are changing? Nobody. Don't worry. You shouldn't, because then you wouldn't have any reason to hire me. You really need. So just so you know, there is a lot. Evaluation management coding has been around a really long time. So it's new to behavioral health groups, but we've had it a long time. There's a lot of physician, what they'll say, burnout from the way that the guidelines are and the things that have to be in the documentation. So they are making strides toward that, and a final rule came out, and we are not going to have any major changes until 2021, so we really don't need to worry about that in behavioral health. So I'm only going to touch upon that because I don't want anybody freaking out. And then we're going to talk about these add-on codes, because I have, in the process of working with agencies and looked at some of your claims that have been submitted, that they're not being used properly. So as much as I can get that in, I will. So not to twerk, but okay. Okay, great. NCCI edit reminders. So there's two types of NCCI. That's the procedure to procedure that you hear a lot of, code pair edits, and medically unlikely edits, and MUEs. These are talking about things that are medically unlikely to be performed more than once on the same day. If you kind of put that out as the way medicine goes, not behavioral health, a big example is obviously once you've had your appendix out, it's medically unlikely that you'll have it out again. But I have heard that people bill more than one of those in a lifetime. Anyway, That's what medically unlikely edits are. But what you're dealing with is the procedure to procedure, things that you're not used to seeing in terms of what CPT codes can be billed on the same day for the same patient by the same agency and all those wonderful things. That's what that is, and we'll talk about that. Go ahead. All right, so specific to behavioral health, the American Psychological Association was very successful in negotiating. And the way we talk about this is NCCI edits are out there, and we have several societies, medical societies, and this one was the Psychological Association, that get involved in making sure that when a rule gets put out there, that it gets justified, or they counter it with, wait a minute, we can do this. And in fact, it's just 2015, so when you think about that, that's only 3 years ago that they had them change their minds in regards to having family therapy and individual therapy on the same day. So prior to then, we had an edit out there that said you just couldn't do it. So they came along and said, well, here are reasons that we do these on the same day, and now there is a way to override that with a modifier. So if you are getting any rejections about those, you'll want to put a modifier on. We'll talk about that. The NCCI manual, this is available publicly. You can download the whole thing. Basically, what you have in this manual is the first several chapters are very specialty specific. So it wouldn't be like you had to read the whole manual. The first part of the manual is very general, saying you shouldn't do this, you shouldn't do that. It's very general. There is, I believe it's chapter 8, if I'm not mistaken. I could be wrong. I've only been known to be wrong a few times, not very often. But if chapter 8 is the psychiatric section that will walk you through some of the CPT codes that you are now using that you weren't used to using before, and some of the rules surrounding that. And when you can override and edit, they give an explanation there. So I would recommend that you at least take that particular chapter and take a look at that. In particular, one of the things, whoops, back.
Oh, sorry.
Although I memorize this, I still have to look. Okay. In particular, one of the things that they specifically say in the general section, what I have down here in the bottom of the screen, is that they want to be sure you understand something. And it's not that I've heard some agencies say this, but believe me, I've heard it in all my private offices as well. If something doesn't go through, slap a modifier on, it'll go through. That doesn't make it right, okay? Slapping a modifier on just to get it through the system and go, oh, it got paid, must be right. No. The modifier you apply needs to make sense. So if you truly did, let's say, for example, an individual session, and it made sense to do a family session following it for whatever reason is going on with your client or your patient, and by the way, they're interchangeable. I've always said patient all my life until I've worked with the agencies, and then client came around. Then putting a modifier on justifies it. If you're not following the rules about something, you just go, I just want this paid because I'm paying my people to do service, and you put a modifier on, that's wrong. And what's going to happen is, if those things get audited, then you're going to have recoupments. So that's one of the biggest things that you probably haven't had an issue with prior, when all you were dealing with was the state and being paid in 7 days. And that was like, you know, a crazy thing for me to hear when I heard, oh yeah, we get paid in 7 days. I'm like, really? What world is this at? Because apparently I had just walked onto Mars, because in private medicine sometimes it's 30, 45 days. And so now that it is, it's for you guys, it's kind of rough, isn't it? Welcome. I'll be a greeter. Welcome to this world of craziness. So basically, the moral of the story is, please, if you're going to put a modifier on, make sure it's justified and make sure that you have the documentation to back up what you did. It doesn't mean, like I said, that it's wrong to put a modifier on. You just want to make sure that when you do, you have a reason. Okay. All right, now this I wanted to take a minute and show you, because this can be pretty daunting if you download the NCCI edits, right? You're going to look at it and go, oh my God, where do I go first? So I like to bring this up. It has the 7 columns, and I put over here what all those 7 columns mean. So let me give you the layman's term, the half-hour speech term. over here in column 1, this is what they call the payable code. So this is the one that when it goes through a system, they're looking at this code first. And I just selected assessment because it's just that much fun to talk about assessments. I couldn't wait to get to this one. Okay, so what we're seeing is in column 1, they're giving a payable code. And what they do in the NCCI edit book, or in this case, you'll get like a huge Excel spreadsheet, is put all the things that could possibly be billed on the same day, which they're going to say, if you bill this on the same day as this, we're going to reject it. How do we know that it will be rejected? This is the other column you want to be looking at. Okay? There's only 2 real choices. Either there's a 0 in there, and no matter what you slap on it, it's not going to go through. And by the way, if it does, they'll come back later and grab it when they realize their system went through and didn't put in an edit. Or there is a 1, which means it's allowed for certain reasons. Okay? So when you're looking at that, and we're looking at assessment, and this one is the individual therapy, there is a 0. That should never be paid on the same day by the same provider from the same agency, is basically what that's saying. Okay, as long as you see a 0 there, it should never get paid. You should never apply it on. Now, in the other instance, if there's a 1 there, then it's saying you can override this. Okay? So although it looks daunting, basically, it's just telling you where did those rules come from, when was the effective date, and the rest of it's a little crazy. You're paying attention to whether or not you can put a modifier on it and grabbing your code. So let me say this out loud. If, for instance, you tried to go look this up the other way, you might not find this. So when you're looking for procedure to procedure, and you have 2 CPT codes that you're billing, check them both in that position. So when you use Excel and you go down, you say, I want to see 90791, you'll see this. In the reverse, it's not there. And people say, well, that's payable, right? You have to look at it both ways. Does that make sense? Okay, great. You can't tell. Some faces are, just kidding. Okay, so psychiatric or psychiatry specific, again, for the individual and family, I know a lot of folks are having trouble with that, getting it through. It can be put through with a modifier. It is valid to have on a modifier, and I'll show you on the next screen. The issue is to make sure that they're separate and identifiable. It's always best practice to have time in and time out, and that just shows the total distinction between the 2. Again, you have to have it clearly identified, and you have to have the time, because remember, these are time-based codes. So go ahead and switch. This screen looks a little bit different. This is out of one of my coding softwares. It's hard to see up there. This has, again, the payable code is in column 1, and column 2 would be anything that you could bill with it. And I don't know if you can see this, but for instance, right beside it, there's a 1 or a 0, means the same thing as you saw on that spreadsheet, and you'll notice that the individual therapy has a 1. So the reason this is so important to you is a lot of folks don't know which one the modifier goes on. So your column 1 code does not get a modifier. It's your column 2 code. So a lot of folks are getting that wrong and sending the modifier on the individual service, and it really needs to go on the family therapy. So again, if you were looking yourself in the manual, you'd be looking for whatever was in column 1 and column 2, and column 2 is the one that gets the modifier applied. Make sense? Okay. This is the Medicaid specific codes. Again, there's an NCCI manual for basically CMS, which we call Medicare, that most of the carriers follow. But Medicaid also has theirs in particular. And this is where you're going to find your HCPCS or your H codes. Again, same thing, column 1, column 2, whether or not you can add a modifier to that. And in this example, we're just going through the H code, so H0011. is column 1, which is the payable, and it's basically saying these are mutually exclusive procedures, meaning you wouldn't do these at the same time, and so therefore you would never bill it, and it would get a 0. However, in this one, at the one above it, you could actually do the G code, which I believe that's expert, and you could apply a modifier. Okay. So not only do we have the one from Medicare that we watch with all the carriers, but we also have to watch the ones from Medicaid. So that's basically all I have on NCCI. I could get really deep on that subject, but I just wanted to make sure you understood where to find the information and how to apply the modifier when you need it. So E&M codes. As long as they're going to be around, I'm going to be in business for a very long time, I think. They're very difficult to understand, and if you have clinician or prescribers that are in your agency that have not had any exposure to private medicine, a lot of times this is very hard for them to understand, and a lot of information that they have to document does not seem very typical to them, but there are very heavy requirements for these codes, and they are monitored a whole lot in private medicine as well as the MCOs. So basically you have your new patient visits and your established patient visits, okay? And a new patient in the rule book of the CPT code is a patient who has not been seen by the same provider in the same specialty, if they're a group, for 3 years. So let's just say your psychiatrist saw somebody and they go on a hiatus and they come back 2 years later and they're in a new episode of care. That does not make them a new patient. It's a 3-year rule. It's a standard CPT code rule. Does that make sense? Yeah, this is the right thing to do. When I see that, I'm like, oh, thumbs up. Most then of your visits will be established, and again, there are 5 levels to choose from. The 5 levels are basically describing the complexity of the patient, okay? So you'll see a 99211 that is in the behavioral health and as well as private, a nursing type of visit. So if you have a prescriber level service happening, you will not bill a 99211 for them ever. Okay, they start at 2 and go up to 5. It's talking about complexity of care for the patient and how complex they are to take care of, and during that visit, what level. Okay, go ahead. There are 3 things that are looked at from an auditing perspective and a billing perspective that you have to have documented. One is the history, which we call subjective. This is the kind of terminology, basically, the prescribers and all the physicians that have been in medicine for a while, the old SOAP note. If you tell them it's an old SOAP note, they get it. The subjective is the history of the patient. What's happening, what brought them here, what's going on currently with them. The actual exam, which is your mental status exam, and your medical decision making, which is going to be the assessment and the plan. And the thing I like to talk about most in regards to the assessment and the plan is this is what key for agencies to understand, that when a prescriber, a physician, a psychiatrist sees a patient and is wanting nursing to follow up with them for whatever reason, nursing services are paid, again, not on the private sector, but definitely for the agencies and the behavioral health redesign, and that provider should put in the assessment and plan order to see nursing for whatever reason. Okay, that's really important, as well as in the treatment plan. But this is when a provider documents the assessment and plan, they're basically giving a treatment plan. And they're saying, I want this patient to follow up with a nurse on side effects of the medication, or good nutrition, or whatever it is that he needs them to do based on maybe what medications he's prescribed or whatever he's ordering. Okay? In the history section, so I'm just going to take each section, history, exam, and medical decision making, and maybe have one slide on it. I can tell you again, I can speak 8 hours on this, so it's really hard for me not to get down a rabbit hole. So if I start doing that, you're going to have to, focus, right? Okay, so in the way that the system works, in terms of what needs to be in documentation is that we look for certain elements, and as an auditor we go through and we say, okay, did they say how long the situation has been going on? Did they say what they're taking to alleviate the pain, et cetera? Had they talked about context? So there's a whole lot in this information that I'm not going through today. For example, again, like I said, what kind of medication are they on? Has it been alleviating? Context, it could be context like work is causing a stressor and this is happening. Those types of things are all put in the history in regards to the patient and why they're seeing that psychiatrist or the prescriber for that day. That's called the history of present illness. Review of systems is a way for a provider to ask questions. Typically, I see it as things like looking for side effects. So if I have them on the med, do you have any headaches? Have you been able to sleep at night? Do you have any numbness or tingling? Those questions all correlate to a scale of checking off review of systems. That's what that is. And then the past family and social history, exactly that. That we're looking at, is there any past medical history for other issues that are going on? Do they have family history of addiction or even past psychiatric family history? Obviously, if they're smoking, drinking, what have you, and anything else. Where they live is a social history, okay? When you say homeless on a documentation, that you're basically saying something about the social history, and these are all counted by auditors. So what we have in auditing, right, is a scale like this to say, okay, depending on how many elements are in the HPI and the review of systems and the past family social history, this looks like the history is X level. That's exactly how we do it, based on everything that's written, okay? A lot of vendors will have templates already there. For the agencies that I have met with, I really like to look at those because sometimes those templates are made for functionality of the software versus what you would look at in an audit. So it's very important to look to make sure that your templates are actually hitting those documentation. So it's sort of like a marrying of what's clinically important to what I have to qualify for the billing code, okay? I usually say if you're putting down good clinical information, chances are you are hitting what's required in the documentation. But I can always take a look at that and let you know for sure, okay? So the exam, that is what we call the 1997 exam. So just briefly giving you a history on evaluation and management coding. In 1995, when they came out, rules came out because they needed to be able to give providers something to benchmark on how do I pick from level 1 to level 5. So they put benchmarks out there. So 1995 came out, and basically what the problem with that was, it wasn't specialty specific. So it was like examining the heart and the lungs and the abdomen and extremities, and then you get psychiatry going, say what? I'm not saying they can't do it, right? They're MDs. They're qualified to do all of that, and some still do. But generally speaking, they're looking at the mental status exam. What's the judgment and insight? What kind of abnormal thoughts are they having? Are they just kind of out there and they, grandeur, not thinking about what actually is going on? Those are types of things that psychiatry looks at. So, it happened to neurologists. It's happened to ophthalmologists. So what they did in 1997, that's why we refer to it as that, is they came out on specialty specific and said, okay, here are your set of guidelines and here are your rules. So it's much easier from my perspective that your prescribers use the 97, unless they're all listening to the heart and the lungs and checking abdomen for any types of things. We don't say they can't, we just say they typically don't. So what this says here, and we'll correlate it to the next slide, so when the next slide comes up it'll make sense, but this helps again say, what do I have to have in my documentation? Well, 1 to 5 bullets equals a 212. So one bullet might be mood and affect. One bullet. So that qualifies for a 2. I'm totally simplifying, but you understand that's what this does. Now, 6 bullets would mean I have an expanded problem focus, meaning I looked at 6 different bullets. But I can tell you generally Most of the documentation I've looked at from the agencies, we're meeting a whole comprehensive because you are looking at everything. We're not just looking at mood and affect. There's so much more to it, right? So let's go to the next one. Okay, so what I want to, if you have the copy of this slide, I want to tell you that this is your like little money spot, your silver bullet, everything, so that you make sure in your exam that this is the bulleted things that you're following. And the reason I bring this to light is that I have seen, like for example, the mood and affect notice is 1 bullet, not 2. So what I was having is agencies create 1 bullet for mood and 1 bullet for affect and counting 2. But that's not how in the auditing world we do it. So we want to make sure that you know how it's set up this way. And again, what we look for is what is in the documentation. So if, for example, I don't have to see physical bullets, right? I don't have to have them numbered. But what they're saying, sometimes they'll say mood and affect is, you know, whatever it is. Where's the other one? Judgment and insight, again, 1 bullet, where folks thought it was 2. There's nothing wrong with having that wrong. But just make sure that you're referencing something like this to say, okay, so generally I guess I could say it this way. Generally what I see is somewhere between a 3 and a 4. This is where we're living in terms of evaluation and follow-up. Now, I'm not saying that you don't have a patient who's a train wreck who wouldn't be a level 5, but generally speaking, we're in between these two, and you just kind of have to look at what the guidelines are, what do you need in the documentation, and then make sure that you're following that. Okay? Okay, then the last thing is medical decision making. I'm trying to be good. Where am I at? I don't even know. Okay. Medical decision making then is number of diagnoses, any data. Now probably don't have a lot of data to look at. In general medicine, this is talking about labs and x-rays and MRIs and diagnostic tests. And I'm not saying you won't have those because some of you will be doing labs. Obviously, if we do a drug screen, that's a lab that gets done. If he looks at it, et cetera, he or she looks at it. Okay, that's a data element. So we're looking at number of diagnoses, the data, and then we're looking at risk, which is a whole nother conversation for a whole 8-hour session on itself. There is a risk table out there, and that is how a patient is labeled as far as risk of, you know, issues or complexity. So just looking at this, again, what I would want to bring out, what would I want you to take away from this? Please, if the patient has more than 1 diagnosis, there should be more than 1 diagnosis on the claim and in the documentation. Okay? However, I cannot overload the documentation with all kinds of items if I'm the provider, if I didn't address them. So what's in the medical decision making is any diagnosis that I address today. So if I'm not addressing something, for example, the diabetes is not an issue. Maybe it is in general with this patient and in terms of the sugars and whatever is happening with the whole behavioral health issue, then that's perfectly fine for them to put on. But if it's not, for example, if they have bipolar, anxiety, something else, let's say an SUD issue, those are all things, if they get addressed, they should be in the note and they should be on the claim. What you always want to be careful with is that with the SUD and the mental health, you know that we have a different set of diagnosis codes. So again, if your psychiatrist is on your mental health certification and they're seeing the patient for that, don't put the SUD diagnosis first. And as Teresa said, it seems like it kind of screwed a claim up if it was on the 4th. But I would say you still put it on. If that's causing a problem, we can remove it from the 4th. But do you want to interject?
I had a recent psychiatrist ask if they had depression and anger issues, if they could count that as 2.
So what we would need to find out exactly how they describe the anger issues. If the anger issues, which probably does, goes back to what we'll call an F code, right, in the ICD-10. If there's something in particular in a behavior disorder, I haven't had them all memorized, so I'm going to say yes, as long as they're treating it. Like if you were having them go to anger management classes, if it's totally putting, you know, a burden on the family from this, that they, you know, go off when they're angry. I'm sure there's a behavioral disturbance in an ICD-10 code that we could find. Yes, as long as they're addressing it.
But we would need to have that anger issue in some type of a code, a diagnosis code.
Correct.
Couldn't just be in the note that they addressed it in their psychotherapy.
Right, so the note needs to say that they did, right? But we're only going to put an ICD-10 on there if there's a true condition, which I'm just guessing with anger, there's probably one out there, some type of behavioral issue that we could probably find. You know, we could take a look at it, but you'll want both of them on the claim because that would increase the level of service and then increase the reimbursement for that visit. That's why it's so important.
Okay, so when you're doing a mental health claim, you can put AOD diagnoses on there to...
So typically, though, when you've got your sort of yes, but no. How's that? Don't go to see Sonda. She doesn't know what she's talking about. She said maybe, maybe not. So in general, let's say you have your SUD clients, but maybe you have a mental health side. You're dual certified, and you say, go see the psychiatrist and make sure, you know, that your anxiety is under control because it seems to be out of control. So they're typically going to discuss the anxiety, and that always should be the first one on the claim. I'm saying if I were telling you, yes, if they address the SUD, it needs to be on there. I'm not going to say, though, that the claim may not accidentally get rejected for that manner, but their primary focus is mental health, and if they're certified under the mental health and they're billing it under your mental health NPI, you should stick with mental health.
Okay.
Be safe. Yeah.
So do you have to only list ICD-10 codes that you manage?
That you managed during that encounter.
Well, so if someone comes in with diabetes, hypertension, et cetera, and it makes them a complicated patient with value-based coding, can you not reflect that in your note, even though you're not actively managing diabetes?
You can reflect that in your note. If you're not correct, if you're not actively managing it, then the way we look at it is every visit stands alone. So if today you're not doing anything about that, and you're not bringing to light in your note why it's complicating things, then we're saying all you're dealing with today is the anxiety. So that code might not be a higher level today, but let's say their sugars get out of whack and now their anxiety's up and it's causing a problem, then maybe the next visit they come to see you, they're going to be a higher level because it is something you're giving thought to. Does that make sense?
Not really, because
Okay.
I understand that you don't want to artificially complicate it, right?
Correct.
So I get where you're going with that, but at the same time, you could reconcile that particular situation by they come in as a new patient, they have hypertension, diabetes, et cetera. You list all of those, demonstrating that they are complicated, but you only code to the level of complication that you manage. So you could only manage their anxiety and code for that, but at the same time, the claim is going out with the appropriate amount of ICD-10 codes to reflect to the insurance company that they are a complicated patient.
That's what I heard.
Correct. So you can put them on, but again, if you are only managing the anxiety, let's say on this visit, it doesn't mean that all the diabetes and the hypertension, all that have to be on there. If you want to, if you're reporting them on the claim, basically what you're saying to the carrier is, I addressed all of these today. It doesn't mean that the patient doesn't have the complicated, how do I want to say that? It doesn't mean that diabetes doesn't go away, the hypertension doesn't go away, but what are you managing today? So if you're going to give thought to them, to those particular conditions today, then you may have a higher level of service. But if you're just managing the anxiety and refilling a med and the patient's pretty stable, you may not want to report them.
I may be wrong on this, but I always thought, like on a claim form, I believe I can bill obviously electronic now, but you see a claim form, you have the diagnosis is listed that this patient or client has, and then you have a diagnosis pointer on the line of the procedure that you're
Correct.
treating them for.
Right.
So why would that matter? It should only go by what diagnosis is pointed for that procedure as far as payment goes,
Correct. So what's your point in putting them all on anyway then?
because it tells the story. You're supposed to have the diagnosis on there, so it tells the story of the patient of why maybe
So if I'm trying to tell a story about, so let me put it this way. So we are going to what we call hierarchy coding, HCC, if you haven't heard that terminology already, where this is going to become important. And I'm just saying, if you are not addressing those, if you want to put them on your claim and only point to A for your mental health, by all means do it. There's nothing that can keep you from that. It's nothing that's going to cause a claim problem. But from a perspective of an auditor, if I am auditing you and you have diabetes, hypertension, hyperlipidemia, and you say in your notes, patient's here for an anxiety refill on Xanax, everything's doing good, they're pretty stable, their mood and affect's great, we're going to refill the anxiety medication, and you've reported all those codes, then I'm going to say you didn't address them, you can't report them. That's from an auditing perspective. If you say to me, we're here for a refill, but the sugars have been just out of whack, and this is going to cause a problem with this medication, and I got to increase this medication and send them to get the sugars under control, then you gave thought to the whole diabetes situation and you put the code on. It doesn't mean that you prescribed a no diabetic, but you're saying this is causing an issue. I can't give them a higher med because this or that's going on and they're not hemodynamically stable, let's say, and I got to get the primary care involved. That's all giving thought to that. So if you do that a lot of times, then yes, they should be on your claim. Okay, I went down a rabbit hole. Sorry.
Now working.
Now it's not working, right? Because I took too long?
It timed out. No,
It's time now. Okay, hold on. Maybe I can get this. How about this?
Fell asleep. Battery died.
No, the whole system fell asleep. That'll teach
There
me.
we go.
Oh,
I think we went too far.
Okay.
You and I both hit it. There we're good, right?
I just hit it again. Try again.
Okay.
There we go. So all I'm going to say about this is the table of risk for psychiatry. Again, we don't have time to go through it. I'm going to go over in my time. It's basically built. It doesn't cover everything. There's just no way it possibly could. But it's just giving you some context to what is minimal, low, and then if you click it, there's moderate and high. This is a guidance to say what, generally speaking in psychiatry, a patient is, whether they're moderate risk or high risk. You have to meet the other elements in order to meet the code, but this particular thing is looked at for the medical decision making. Okay. These are just tips for documenting severity, and the reason I say this is because when your claims get audited, not always will there be an auditor at the MCO who is psychiatry trained in psychiatry or behavioral health. A lot of times they do that, but you want to make sure that you put some words in. Now, I'm not telling you make this up, so let's get that straight. What I'm telling you is if any of this applies, make sure you use these words. Severe, significant symptoms of whatever it is. A new onset. Okay, so there is a huge difference between whether somebody had anxiety and now they have a new onset of depression versus somebody who has anxiety and depression, they've had it for years and it's chronic and it's stable. The new onset of an issue becomes very important. Maybe they're not sleeping, but again, if they're never a sleeper and they only, they're psychotic. No, I'm just kidding. Kind of bad for this section, right? Bad taste for this working group. Not sleeping would be something that you would want to make clear if it's definitely affecting them the rest of the day and they're not taking their medications, are taking their medications, things like that. Suicidal ideation. Okay, this would be a current. Okay, you can put in the record they had a previous history of suicidal ideation or even an attempt. That is important. That history piece is very important with that patient. But again, anytime that it is very current, this puts them in a very high complex area. Threatening or combative behaviors and sudden exacerbation. So if they have an issue starting, that's important as well. Okay, so time. And I don't know where I'm at time-wise here. Coding based on time, you just want to make sure that for an evaluation and management code, you want to be able to say 50% or more of the time of this was spent in counseling the patient, total time spent X. Okay, so just having the time in and time out of an evaluation and management code is not enough. So this is the way that this can be paid and paid compliantly. Okay. The counseling and coordination of care, sometimes we get these words a little bit mixed up, so I wanted to make sure I had a slide on that. So in an evaluation and management, you can, remember, add on psychotherapy. And psychotherapy, even though we refer to that as counseling sometimes, individual counseling, it is different in terms of the CPT code. So for counseling and coordination care for an evaluation and management, they're referring to talking about diagnostic results, talking about a med that you're starting, the risks and the benefits of doing such thing. They may be going through a total talk with the patient in regards to, okay, this is how we're going to approach it. I'm going to send you to group. You're also going to have an individual counseling. We're going to give you a case. That whole time that their counseling and coordination of care is trying to give the patient a view into what they may be taking, what side effects it might be giving them, and what the treatment plan is. That's the counseling coordination of care. So I know that one's a little bit harder to think about, but the reason I go into this in particular is because, remember, old world was everything was time-based. And so you cannot take evaluation and management codes now and slip it into that time base, because time only applies if the driving factor was counseling and coordination of care. And then again, psychotherapy, I don't really probably need to give you that definition, but that looks a little bit different. And again, your prescribers can do the add-on psychotherapy code with your E&M, and that would be timed in particular to psychotherapy, and we would actually want to see some of that in the record here, what we have listed on the slide. Okay.
I just want to chime in for a minute. Obviously, we're running a couple minutes behind schedule. Not exactly sure where that happened. It was probably walking around and running around the room. But I want to let Sonda finish, then we'll get a break, get Chris started, then Chris started, and we'll get through it. But please be patient.
Told you I would go down a rabbit hole. This is what I was talking about before, that if you had not heard, we have some new rules coming out. Let's get through these really quick, because what I don't want to do is confuse anyone. So just really quick, because we have such an issue with evaluation management code, so it's new to you guys and it feels really difficult to maneuver through. As long as it's actually been in the medical community, it's been very difficult. There was a survey done, and basically 60%, they found 60% of the time providers are selecting the wrong code anyway. So again, this is a process. You'll learn how to do it, and they'll learn how to pick the right code. But what they were doing was they were going to put and this is happening in 2021, is they had level 5 where they were just going to get rid of it. That was the proposed rule, and they came around and said, okay, we're not going to do that. We had enough feedback. So I don't really want you to worry about that. There's some immediate things that if you are working with me now that I will talk to you about, send you an email, that they are alleviating some of the administrative burden beginning January 1. So I'll do my best to blog about that, or get out a newsletter to all my clients that there are some things that before I would teach you that, yes, you have to repeat that even though your medical assistant wrote it. And now they are alleviating that beginning January 1, 2019, where you will not have to repeat certain things. That's all I can say about that. Add-on codes? Okay, make sure when you have the evaluation management and the psychotherapy, you do not have to have a completely different note. You'll have your therapy right in the evaluation management. Just make sure it is separate and identifiable and has the separate times on it. Okay, this one is the most misunderstood codes. Remember, the prolonged services go with the code, and it is after you've reached the time factor. So for example, I'm just going to give what I saw, and that was 90837, which is the 60-minute, and the 99354 would indicate that you have spent over 90 minutes in psychotherapy with the patient. I think what folks were doing is once they hit the halfway mark, they were adding this particular code on, and it wasn't coming out correctly. So I want to make sure you understand that when you add on prolonged, it means that you've completely passed the full hour of psychotherapy. Okay. Interactive complexity. I think this is a rabbit hole we may not want to go down either. Go to the next slide, and that's what I just want you to know, that I specifically spoke to the American Academy of Child and Adolescent Psychiatry, because when this first came out, what I was hearing was that if you were seeing children, all of your children were interactively complex. And that is not correct. And in fact, the association, I am giving a direct quote, which says, it would not be appropriate to advise clinicians to use the interactive complexity code anytime they provide psychotherapy to children. And in fact, I suspect such use of the code would put clinicians at increased risk of audit. All I want to say about that is each patient is remember we keep saying individualized. Some children are difficult, more difficult than others. I am going to say that it is a clinician who decides that, not me. But I would want to see something in the record that clearly indicated why you felt you wanted to add on interactive complexity. And remember, we're only talking about what, an add-on of somewhere between $11 and $15. It's not like a whole lot, but just use it when it's appropriate. Super stuff. I'm done.